Hi everyone, I'm Bobby. I'm going to tell you about the difficulties experienced by GERD patients and explain how simple changes in our practice can have a profound effect on their symptoms and quality of life. Here's some of what you can expect from this presentation. First, a definition of GERD and an explanation of the mechanics involved. We will outline the PICO question, followed by a summary of research strategies, results, and a synthesis of the literature. The proposal will be outlined and the evaluation plan will be described. And finally, we will describe the expected outcomes based on the evidence from the literature. GERD is defined as chronic retrograde flow of gastric contents from the stomach up into the esophagus. Prevalence is high. Statistically, in a class of 20 adults, it's likely that at least 4 have GERD. And that goes for the rest of the world too. But the numbers continue to climb. GERD has been plaguing humans for centuries. Through the years, treatment methods have evolved. 4,000 years ago, Chinese herbalists used extracts of seminal fluid and baby urine to relieve symptoms. That's not even the strangest of the remedies, but that's a story for another time. In the 1400s, when Da Vinci was making detailed diagrams of the digestive system, it was understood that the stomach was an acid environment. There is evidence of the use of powdered coral and powdered pearls to treat the symptoms of GERD using calcium to neutralize the acidity. The symptoms can be troublesome in and of themselves. Gastric contents backflowing up into the esophagus exposes esophageal tissue to acid levels that it's not meant to be in contact with. This chronic exposure causes DNA damage to the distal esophagus, and high-grade dysplasia is called Barrett's esophagus, and that carries a high risk of developing esophageal cancer. Today, we treat GERD by lowering the acid level of the stomach contents through medication. But this treatment over a long period of time is not without its drawbacks too. GERD symptoms are so common, but why are they such a big deal? Let's take a look at the anatomy. The image on the left shows a normal upper GI tract with an intact gastroesophageal sphincter. On the right, you'll see how laxity of the gastroesophageal sphincter allows the contents of the stomach to spill or effervesce upwards into the esophagus. Laxity can be influenced by several factors, many of which are modifiable. Another mechanical reason for GERD is the presence of a hiatal hernia. Normally, the GE junction is at the diaphragmatic line. A hiatal hernia is when a portion of the stomach herniates up through the diaphragm. This creates a pocket that can retain gastric contents, increasing the probability that those will make their way back up into the esophagus. While a hiatal hernia may sometimes be caused by modifiable factors, once you have it, it can only be fixed with surgery. However, there are many behavior changes that can help with GERD symptoms, even in the presence of a hiatal hernia. The practice problem. The standard of care is to prescribe H2 blockers to reduce the acidity level of gastric contents. H2 blockers reduce acidity by 50%. This way, when reflux happens, there's less damage to the esophageal tissue and less pain. More often than not, H2 blockers fail to relieve symptoms, so the prescription frequency and dosage increases. That works for a while, but eventually, refractory symptoms persist. After undergoing an esophagogastroduodenoscopy, or EGD, a proton pump inhibitor is prescribed. PPIs can reduce acid level by 90%. Eventually, refractory symptoms return again, and you can probably see the pattern that evolves here. But the problem is twofold. First, patients' quality of life suffers due to the effects on social interactions and symptoms that impact sleep and breathing. All of these have significant downstream health effects. Second, Long-term use of PPIs can lead to micronutrient deficiencies, including B12, magnesium, and calcium, because foods that contain these micronutrients are not being broken down completely due to the neutralized gastric secretions. And this can lead to fractures from the mineral deficiencies and mental health problems because B12 is a cofactor for the synthesis of serotonin and dopamine. As a GI nurse, I encounter many GERD patients who report feeling that their symptoms control their lives and that they have no control over their symptoms. Nearly all of those patients are not aware of lifestyle changes that may have a significant impact on their experiences. So I had an idea. What if patients knew that making changes to habits and behaviors could reduce symptom severity and limit refractory symptoms? The PICO question is, in GERD patients, does lifestyle modification education compared with medication alone influence refractory symptoms and quality of life? To look deeper at this question, I used Google Scholar, PubMed, and CINAHL Ultimate. In the search terms, I used both GERD and GORD, GORD reflecting the UK spelling of esophagus. Inclusions and exclusions. As for all that was included, the date of publication had to be a maximum of 5 years ago. The subjects had to be human adults, and the articles had to be either primary studies or review articles. I excluded papers that didn't have the full text available and were not available in English, and there are a surprising number of studies on non-human subjects, especially dogs, and a lot of studies in pediatric subjects. All of these were excluded as well. This is the diagram of the search strategy. So I started off with 2,556 from the original search, of which 852 were discarded right off the hop for being duplicate or irrelevant. There's a bunch in here that were discarded for the exclusion and inclusion criteria, and then a further 13 were excluded for not being very high evidence level and being low quality. So I was left with 5 primary studies and 4 reviews or meta-analysis. 5 main ideas emerged from the primary studies. These include modifiable factors impact patient experience of GERD symptoms, patient education improves symptom profile, lack of knowledge of lifestyle factors is correlated with unsatisfactory outcomes, including quality of life, patients' desire to know that they have any control over their symptoms, and finally, knowledge of lifestyle modifications positively affects quality of life. There are also 5 main ideas that emerged from the 4 review articles, and these include not knowing about lifestyle factors affects symptoms and results in poor outcomes for symptom profile, increased medication use, and low medication adherence. Patient education improves outcomes regarding symptom profile and medication adherence. Knowledge of lifestyle factors is correlated with less requirements for medications for refractory symptoms. As symptom profile worsens, incidence and severity of psychosocial disorders worsens too. And finally, lifestyle education led to improved quality of life. The ARC model emphasizes the importance of buy-in from all the stakeholders. Stakeholders here include nurse practitioners who will execute the health education, physicians who may scope GERD patients less often as the patients gain more control of their symptoms. I included scheduling and billing staff here because both will be impacted by the nurse practitioners having more contact minutes with each GERD patient. I also included an office administrator as the key person for ensuring that educational material is available for both in-person and virtual appointments. And finally, the patients, of course. Now, the next step is to gather baseline data about quality of life and symptom profile for the GERD patients. We will need to create the printed and electronic education material. And also, finally, longer appointments will be necessary, so that scheduling needs to be arranged. As for the lifestyle changes that we will advise, here's a sample of some of the do's and don'ts that we'll base our health teaching on. Evidence suggests that short walks after meals encourages gastric motility. The sooner the stomach can empty, the less chance there is for reflux to occur. Upright posture, or at least not reclining for a minimum of 3 hours after any meal, utilizes gravity and the upper GI anatomy to ensure that gastric contents don't have a chance to spill upward into the esophagus. Adhering to the prescribed medicine regimen is key. Also, either working towards a healthy weight or maintaining it, because body habitus influences the amount of pressure that the stomach exerts on the diaphragm and the gastroesophageal sphincter. Things that are to be avoided, and this is a little bit different for everybody, but the common ones are acidic foods such as coffee, tomatoes and tomato-based foods, citrus, chocolate, alcohol beverages, avoiding large meals because, again, that puts a lot of pressure on the diaphragm and the gastroesophageal sphincter. Consuming liquids with meals just adds to more volume in the stomach for the very same reasons. And no meals within 3 hours of bedtime because of that upright posture. And avoiding smoking because that's strongly correlated with GERD symptoms as well. So we're going to evaluate our evidence-based plan based on the ARCC model. We're going to collect and compile patient quality of life data and the symptom profile data in order to compare that with the baseline. We're going to share the data with all the stakeholders, including the patients. And we're also going to check in with stakeholders on an ongoing basis to identify perceived barriers as the program continues. We'll also compile and provide data pertinent to each stakeholder. And lastly, we're going to remain open to pivot to any alternative programs such as group education sessions, either in person or online if the need arises. So in conclusion, we know that the evidence is showing that patients want to feel some control over their symptoms. Patients do not already know about lifestyle changes that might improve their symptom profile. And we also know that lifestyle education for GERD patients results in improvements in both quality of life and symptom profile, both things that we definitely want for our patients. We want to do better by our patients, and now we have a plan. Investing in education is like the gift that keeps on giving. Educating our patients is a way to increase the dialogue about one of the most common ailments in the world. Each one teach one, and on it will go. It starts here with a simple evidence-based plan. And here are some references for you to peruse, and more references here. Thank you.